Welcome to Clinical Toxinology. Is it relevant to medical students? This clinical webinar series is now at Season 5, Episode 1 under the supervision of Prof. Kauden. My name is Yingju.
And my name is Saloni.
And we'll be your moderators for this afternoon. It's a pleasure to have all of you joining us. This webinar is organized by the Department of Emergency Medicine of Hospital Chancellor Tuanku Mukhris. For your information, we also collaborated with several esteemed organizations to ensure the success of this webinar, namely Remote Evaluation Consultation Service, REX, Malaysian Society of Toxinology, Special Interest Group in Clinical Toxinology, College of Emergency Physicians, Academy of Medicine Malaysia, Malaysia Biodiversity Information System, National Poison Center, University Science Malaysia, and ToxSet.
Before we begin, here are a few housekeeping notes. Participants are most welcome to turn on their cameras. Please keep your microphone muted throughout the session unless invited to speak. Use your full name as your display name for identification. And kindly post your questions in the chat or Q&A box. They will be addressed during the discussion session. Please do not interrupt the speaker and wait for the moderator's cue before speaking. Recording, screenshots, or screen capturing are not allowed unless officially permitted by the organizer. Maintain professionalism and respect communication at all times. For technical issues, please rejoin the meeting or inform the organizer via the chat. Also, a gentle reminder that there will be a Kahoot quiz session at the end. Do stay tuned and stand a chance to win the grand prize, which will be awarded for the champion.
Now, join me in welcoming Dr. Irene Zamhot, Emergency Medicine Specialist at HCTM, and our Head of Module for the Year 5 Emergency Medicine posting to deliver the welcoming remarks for today's webinar. Please, Dr. Irene.
Okay, Assalamualaikum and good day everyone. My name is Dr. Irene Zamhot. I am the Head of Module for Medical Students. A very warm welcome to all participants to this webinar on Clinical Toxinology Season 5, Episode 1. First and foremost, I would like to express my sincere gratitude to the organizers for inviting me to deliver this opening speech for this webinar. I commend the team for choosing clinical toxinology as the focus of today's session. As an emergency physician, I can confidently say that our work frequently brings us to face-to-face toxinology-related emergencies. So these cases often present with vague or non-specific symptoms and can rapidly progress to severe morbidity and even mortality. For medical students, early exposure to toxinology is invaluable. I really hope this webinar will inspire you to think critically about how these principles are applied in real-world scenarios. I would also like to take this opportunity to sincerely thank our esteemed panelists, Dr. Muhammad Naim Abdul Razak, Professor Dr. Anjana Silva, and Dr. Nikhil Paul for joining us today. We are truly privileged to learn from experts from this field. Your willingness to share your knowledge and expertise is invaluable to those listening. A special note of appreciation goes to Professor Dr. Kauden for his continuous encouragement of the students' participation and for your dedication as the program advisor. Your support and guidance play a crucial role in motivating and preparing the students for their role as future doctors. Lastly, I want to congratulate to the organizing committee and all participants for making this webinar possible. Your commitment is truly commendable and I'm really proud of each one of you. Thank you. That's all from me.
Thank you very much, Dr. Irene, for your insightful and encouraging remarks. Now, let's take a moment to introduce the team behind today's webinar. This webinar is proudly organized by the Year 5 Emergency Medicine Posting Team under the guidance of Associate Professor Dr. Ahmad Khaldun Ismail, Emergency Medicine Specialist at HCTM. We are truly grateful for his invaluable guidance and support in making this session possible.
Now, let's get to know our panelists for this webinar. Today, we are fortunate to have with us three experts who will help us explore this theme through real clinical cases. Let me introduce Dr. Muhammad Naib Abdul Razak, Senior Registrar in Emergency and Trauma Department at Hospital Lahad Datu, Malaysia. Professor Dr. Anjana Silva, Toxinologist, Professor and Head Department of Parasitology, Faculty of Medicine, Rajarata Uni, Sri Lanka. Dr. Nikhil Paul, Assistant Professor of Emergency Medicine, Kasturba Medical College, Mangalore, Manipal Academy of Higher Education, India. Thank you all for being here with us today. Now, Inju, I believe we can officially dive into clinical toxinology. So, can you please introduce to us what clinical toxinology is?
So, clinical toxinology is a medical subspecialty concerned with the diagnosis, clinical assessment, and management of envenoming and poisoning caused by animals, plants, mushrooms, and bacterial toxins. So, what is toxin? Toxin is a poisonous substance of biological origin produced by living organisms that can cause harmful physiological effects when introduced into a living organism. Since envenoming and poisoning was mentioned, so what is the difference between these two? Envenoming refers to the active injection of venom into a human through a specialized delivery apparatus such as fangs, stings, spines, or nematocysts. Venom is typically introduced parenterally, for example, subcutaneous, intramuscular, or intravascular, and contains biologically active toxins designed to immobilize prey or for defense. Poisoning, on the other hand, refers to toxic effects following exposure to a poison that is passively encountered without an injection mechanism. The toxin usually enters the body via ingestion, inhalation, or absorption through skin or mucosa. Before we go further, I would like to clarify an important concept that is often misunderstood, the difference between venomous and hazard level. An organism that is equipped with venom is called a venomous animal. What defines a venomous animal is not how dangerous it is to humans, but the fact that it actively uses venom, either for prey capture or for defense. Now, the effect of venom on humans depends on several factors. Most importantly, it depends on the potency of the venom and the dose of venom that actually enters the body. Because of this, the clinical severity of envenoming can range widely from potentially deadly, dangerous, not dangerous, or harmless. This leads to an important takeaway. An animal is either venomous or non-venomous. There is no scientifically meaningful category in between. Terms such as highly venomous, moderately venomous, or mildly venomous animals are not accurate descriptors in the toxinology. They tend to confuse the concept of venom delivery with clinical hazard. Instead, what we should be discussing is hazard level to humans, which is influenced by venom dose, route of exposure, and circumstances of the encounter, not whether the animal is more or less venomous.
Before this webinar, we have conducted a survey among 45 final year medical students in the current emergency medicine posting at UKM to assess their awareness and confidence levels in clinical toxinology. So, based on the survey, more than half of the students are unsure or not aware about what clinical toxinology is all about. As we can see here, about three quarters or even more of the students are not confident in providing information on the appropriate safety and health seeking behavior regarding toxin injuries, such as informing the public that toxin related injury is a medical injury, various emergency services that are available for toxin injuries. Also, less than 20% of the students are confident in providing information on the role of remote envenomation consultancy services, also known as REX, which offers training and 24-hour on-call consultation service in the clinical management of toxin-related diseases to the healthcare professionals in ASEAN since 2010. Again, majority of the students are not confident in sharing their knowledge, such as identifying common signs and symptoms of a toxin related disease, appropriate first aid measures for acute exposure to natural toxins, various sources of natural toxins, emergency hotlines, guidelines, and resources for toxin related disease, and also appropriate antivenoms that are available in Malaysia. Similarly, majority of the students are not confident in providing instruction or information on how to identify a potential toxin surgery, administer the appropriate first aid, emergency procedures in cases of suspected toxin exposure, important history details that need to be obtained, and where one should be transported to after a toxin injury. So in summary, we can see that majority of the students are not well aware about clinical toxinology. Hence, it's our hope that this webinar will shed some light on this topic, which is relevant to the medical students and healthcare professionals, as our country has diverse venomous or poisonous species in the forest, under the water, or even in our own house.
So in this webinar, we are going to discuss a few clinical cases with our expert panelists. For your information, these are actual clinical cases in Malaysia that were referred to RACs in the past. Without further ado, let's begin our first case discussion. In our first case, we have a 56-year-old Malay female with no known medical illness. The patient was tidying up her kitchen when she was allegedly bitten by a black snake over the right second toe at around 8:30 p.m. She did not notice the snake until after being bitten, and there was no hissing sound heard prior to the bite. She was unsure of the species of the snake. Immediately after the bite, she experienced localized pain at the bite site, following shortly by blurring of vision, shortness of breath, generalized weakness, and bluish discoloration of the affected foot. She was then brought to the emergency department, arriving at approximately 30 minutes post-bite at around 9 p.m. Now, the discussion is open for the panel. Is there any additional history that the panelists would like to inquire about? So maybe Dr. Nikhil, do you have any question that you would like to ask about the further history of this patient?
Thank you.
Right. So what you have mentioned is you had bluish discoloration of the affected foot, right?
Yes.
Uh, Only on the affected foot,
Yes.
nowhere else, right?
Yes, only the affected foot.
Right.
So now let's review the questions asked by the Remote and Management Consultation Service, the RECS, for further history. First, had anything been done to the bitten area before arriving at the emergency department? The answer provided by the family is no. Second, how did the patient get to the hospital? She was brought by her daughter who stayed with her via car. And third, when exactly did the patient collapse? According to her daughter, she collapsed on the way to the emergency department approximately 8:50 p.m. So upon arrival at emergency department, the patient was found to be in cardiac arrest. There was no spontaneous breathing, no palpable pulse, and the oxygen saturation was not recordable. Cardiac monitoring revealed asystole. Cardiopulmonary resuscitation was immediately initiated and continued for 8 minutes. During the resuscitation, intravenous adrenaline 1 milligram was administered twice. The patient was intubated and mechanically ventilated on fraction of inspired oxygen 100% and positive end expiratory pressure of 12 centimeters of water. Return of spontaneous circulation was achieved after 8 minutes of CPR, and ventilator support was maintained and the post-return of spontaneous circulation monitoring continued. So at this point, how would the panelists explain the cause of cardiac arrest in this patient? So can Dr. Naim answer the question?
Hi, Inju. That's a very nice case presentation. But before I proceed further, just to confirm with you, may I know where is this case occur exactly, the geographical location?
It's in Johor, Batu Pahat.
Right. That's awesome. Right. So this is one of a quite very interesting case that a patient was bitten by snakes and suddenly developed cardiac arrest. When tackling this issue, you need to understand on how the venom works. So the snake venom, it has different type of venoms. Some are neurotoxic, some are hematotoxic, and like in this case, most likely that he was bitten by snake that cause a neurotoxicity. So the example is, would be the some snake elapis. So I'm taking a guess. He was possibly being bitten by cobra. So what happens that once you've been bitten by the neurotoxic snake, it causes descending paralysis, and your basically your lung will start not your diaphragm is not going to move. You're going to be paralyzed. Your respiratory muscle will be paralyzed, right? And so on some of the snake venom, it also has a direct effect on the heart, so cardiotoxin. And once your breathing stop, and then your body will actually have the hypoxia, the hypoxic. So it can be because of that thing, because can be the hypoxic arrest. It could be because of the direct neurotoxin effect and also the direct cardiac effect. So there are many things that can occur in this case, but definitely this is effect from the envenomation because she's not been taking any other things on prior to the collapse. Right.
Thank you, Dr. Naim, for your valuable input.
Maybe
Just yeah.
Prof. Anjana would like to add on. I know everybody is itching to answer this. It's very interesting, right? So please go ahead, Anjana.
Yeah, yes, thank you, Ram from Scalding. Yeah, so this it's a very interesting case where everything happened quite quickly, I guess, from the bite to the collapse. It took around, like, I guess, 20 to 30 minutes. So it's a quite rapid collapse. And then, according to the history, it can be due to neurotoxicity, or maybe cardiac arrest, or probably cardiac arrest precipitated by the respiratory failure first. So they all can be there. The other important thing I noticed was the bluish discoloration of, I guess, the bite site. So I could not really verify whether it is actually the bite site or just the leg hole area. But assuming that it's around bite site, now there are two things we all agree. I think it's clear that this is likely to be a neurotoxic snake, and then the distinction should be what kind of neurotoxic snake this could be. So I guess in your setting, cobra bites, as well as you have crate bites as well, I guess. But I'm not quite familiar with the geographical region, or whether it's a possibility in that specific region. But what is really interesting to me is that how fast these things develop. If it is a cobra bite, usually a post-synaptic neurotoxicity, because of that rapid development of paralysis involving respiratory paralysis, and you will not see the typical descending paralysis in a cobra bite, because usually they happen quite quickly compared to a crate bite, where pre-synaptic toxins take some more time for the paralysis. And also here, the other thing is, other thing that favors cobra bite here is, I guess, the cardiac arrest, because usually cobra bites also known to cause cardiac arrest because of their cardiotoxins. And also the other thing is, if this bluish discoloration at the bite site is due to the early local effects, then again it favors cobra bite rather than crate bite. So I at the moment, with this available information, what I see is it's can be a cobra bite.
Yeah. Okay, Nikhil, want to add on a bit?
Yeah, the same thing. What I was only thing what I was confused was the whether the bluish discoloration is a general cyanosis or the because of the local effects of the venom. To me, it looks like cobra because of the direct cardiotoxicity which is there for cobra, and also rapidly developing neuromuscular paralysis, which has probably caused a respiratory failure and a hypoxic arrest. That
Okay.
might be what I am thinking of.
Great. So I would like to also add on a little bit. I would commend Dr. Naim's asking where was the incident location. So you're rightly asking that question, because then we would know what type of cobras are there in this area. Yes, we have cobras, two types of cobras in Malaysia, two species of cobras. That's the Naja Kauthia and Naja sumatrana. And in Johor, depending on where you are, most likely it is a Naja sumatrana, the equatorial spitting cobra. We were not provided the information whether there was a spitting incident, but there was no so-called like hissing sound, which is actually supposedly the spraying of the venom or blowing of the air from the snake. So we don't know that, therefore we don't speculate. But there is certainly a sign of neurotoxicity, most likely from the Naja species. And in this area is most likely from Naja sumatrana. The other point is that I think nobody was asking what did the patient do before arriving to hospital or after the bite, because as we know, certain intervention can actually expedite the spread of the venom from the site of bite to the whole systemic, which she is actually already having. It's not just a local envenoming anymore. It's already going to systemic. So what did she do would be a good question to ask. That might give us some explanation why this thing moves so fast, which is more than 30, about 30 minutes, right? From the bite. So, okay, let's move on. Maybe our moderators can highlight further what we have identified during the consultation.
Subsequently, physical examination was done. Post return of spontaneous circulation, the patient remained deeply comatose with the Glasgow Coma Scale of 3, scored as E1, verbal unaccessible due to endotracheal intubation, and M1. And the blood pressure was 166/104 millimeter mercury with a tachycardic pulse rate of 140 beats per minute. Oxygen saturation was 85% despite airway support, and then the behavioral pain scale was 3. On respiratory examination, there were coarse crepitations over the right lower lung zone. Cardiovascular examination revealed a dual rhythm with no audible murmurs. Abdominal examination was unremarkable with a soft, non-distended abdomen. Examination of the right lower limb revealed 2 distinct bite marks, one over the big toe and another one over the second toe. There was bluish discoloration involving the big toe and the second toe, extending to the dorsum of the right foot. Sensation could not be assessed due to the patient's reduced level of consciousness. Distal circulation was preserved, with both dorsalis pedis and posterior tibial pulses palpable. Capillary refill time was less than 2 seconds in all toes except for the second toe. The rate of proximal progression at this point was 0 centimeter per hour. The compartments were soft, no clinical features suggestive of compartment syndrome.
Okay, I think the vital signs just now most likely is post resuscitation tachycardia from the adrenaline. So we can't judge much from that as a progression of the envenoming. Okay, you want to show us the picture, the bite
Yes.
side?
These are the pictures showing the bite side of the patient.
Yeah, so here there's some discoloration that I can see, and towards the dorsum of the foot, I guess slightly like it's the area, whole area is erythematous. I'm not quite familiar with the the Naja species, Naja Kothia, Sumatrana envenomings, but in what the cobra species that we see, usually they get most of the time get 1 or 2 blisters around, but here I'm not quite sure whether you get blisters so often. But I guess
so this is still early. I think this is quite early, right? Moderators, this is early pictures.
Yes.
On arrival.
Yeah. Is this
so
just
maybe it's
30
still
minutes?
Evolution. Yeah.
Yeah. Okay. Too early. Yes. Yeah.
Nikhil, want to comment about the wound?
Yeah, there is definitely bluish discoloration, but then it is not crossing midfoot, I guess. So still
not yet.
localized. Yeah.
Still early. Okay.
No, I'm wondering
anyway,
whether the bite was directly into a vein or something, like a superficial vein or something.
no, but you can see it's
Yeah.
the question that we typically ask a doctor, what do you think? Is this ecchymosis or is this necrosis? Right? So there is a very distinctive feature here which points towards thermonecrosis. It's not ecchymosis. So
Not ecchymosis.
no, definitely not. So the bite is also quite significant, and you can see the snake was very angry. It's really, biting through the toes and the big toe and the second toe. And there's no what we call active bleeding from the side. There's a clot at the bite side there, you can see. But it was actually really angry snake. And judging from the wound size and the distance between the two, it could be quite a significantly big cobra that caused this bite. So these are the things that we generally will be looking at when we are looking at the wound and the bite side. So this is definitely a cytotoxic effect locally, causing the pneumocrosis, which is pathognomonic. For Malaysia, it's from the two Naja species. Okay, all right. Naim, can you see already?
Yeah, somebody sent me the picture in the WhatsApp group. Yeah.
Okay, all right. Okay, so let's move on.
Now, let's reveal the video that the family had sent.
Okay, we forgot to ask that, huh?
Bro.
Yeah. Yeah, it's quite big.
So, panelists, what do you think is the species of the snake?
So does this look like a forest spitting cobra?
Okay, so this is a typical feature. You can see the ventral side of the head. It's typical, no typical striation or stripe. So this is a Naja sumatrana. So it's a spitting cobra, and it's from judging from the size, looks like quite a big size, and therefore the injury that occurred or severity was quite severe. So okay, so what happened to the snake actually?
And the snake was killed by the family member.
Immediately after?
Yes.
So they found the snake in the kitchen.
Yes.
Okay. All right. So that's important question that we have to ask. We always forgot. We sometimes to concentrate on the patient, but we forgot the surrounding incident, right? So what happened to the snake? Where's the snake? Is there any picture of the snake? Who killed the snake? What was done and so on. So therefore, this is very helpful. Just now was initially a bit blur about which species, but now we are already pointing it down to the species level. Okay, so that's why we have to ask all this question and documentation. All right. Okay.
So our impression so far was Naja sumatrana inflammation with severe neurotoxic effects resulting in acute respiratory failure and hypoxic cardiac arrest. The immediate management done by the attending doctors was giving 10 vials of Naja cotia antivenom to the patient. It was started at 10:10 p.m. and completed at 11:45 p.m. So now I have a question to the panelists. Would the panel agree that antivenom was indicated here? What are the indications for the antivenom administration based on the patient history and also the physical examination?
Yeah, so anti-venom is definitely indicated in this case. Obviously, it the Nacha Kotia anti-venom was given. Yep. So it's a monovalent anti-venom, but then it was identified as a Sumatran spitting cobra, right? I think cross reactivity is there, I guess. So if this was in our part of the world, definitely we don't have a choice. We don't have an anti-venom. But then I think the anti-venom for Naja-Kotia has cross-reactivity. The indication, I would say, a patient was in respiratory failure and still requires the treatment at that point.
Okay, very good. Anjana, you have
Yeah, so
experience
I
with
also
Thailand, so
yeah, so I also agree. So definitely there's indications for antivenom. Patient is having severe neurotoxicity, and the other important thing is compared to crate bites, cobra bites usually respond to the antivenom quite well because of these are basically because of long chain postsynaptic neurotoxins and short chain neurotoxins. So they basically respond to the antivenom very well usually, and will lead to a reversal of neurotoxic envenoming usually if the antibodies cross react with the toxin. So I think this is the correct management.
okay, good. Naim, would you like to bring in some information or perspective from Sabah and Sarawak regarding antivenom?
Yes, thank you, Prof. Yeah, so far in Sabah, we do not have any Naja Kautia in Sabah. But however, we do store two types of antivenom for the neurotoxic snake, which is the polyvalent antivenom and also the Naja Kautia antivenom. However, because of based on the study, the Naja Contia antivenom is able to cross neutralization the venom from the Naja sumatrana bite. So based on the cases that we have for the past 10 years, the most common neurotoxic snake bite was actually from the Naja sumatrana rather than any other snakes. So as far as I remember, for the last 10 years, we only have one cases of bitten by the king cobra and also one cases of bitten by the Bungarus fasciatus, and I think less than 5 cases of being bitten by the sea snakes. So far for those patients who presented with the neurotoxic symptom, even though that the patient did not bring the snake, but if we look at the bitten site that show the pathognomonic of the Naja bites, which is the pneumococcosis, so our first line of antivenom will always be the Naja cautia antivenoms rather than going to the polyvalent antivenoms. Yeah.
Great. So I just want to add on to ask what the panelists feel. What would be your sort of like cut-off point when you would consider giving antivenom to a patient? In this case, there's no argument. It's always acute, and it's still acute and in developing phase where we don't know how bad is the local environment going to be, how far, and so on, and also can it reverse the systemic envenoming, right? But what would be your take on the first dose of antivenom when you say, oh no, this is not going to work anymore? What do you think, Anjana?
So, well, I think it differs on the type of the snake. In our setting, especially, we get mainly viper bites, Russell's viper and hump nose, where we have, we see patients developing thrombotic microangiopathy and then AKI even after like 3 days. So, in our setting, what we say is that there's never a delay for antivenom. So, if the patient comes late, even you can give. That's what we practice. But for neurotoxic envenomings, I guess if they are going to develop neurotoxicity, they usually develop within the first 6 or 8 hours. But then after that, they are not going to develop. That's what that's our experience in our city.
Nikhil, what about India?
Yeah,
How long would you consider not giving antivenom?
yeah, like Dr. Anjana said, like we share one common snake, especially in Sri Lanka and Kerala, which I'm part of. We have also the Hamnos pit viper.
Yeah, yeah.
So these are this snake is found only in these two areas as of now, like
The
Western Ghats
Hypnale,
and
right?
yeah, Hypnale. And also we have a
Yeah,
lot of other viper bites, which are predominantly more than the neurotoxic bite. Of course, we give antivenom even late for vipers and but neurotoxic snakes, especially after the first few hours, we go for early ventilation strategies. If not, patient is not improving. That's what we commonly do it. But then, as early as possible, if they present to the emergency, so our indication would be early onset of systemic symptoms, which includes respiratory symptoms or neurological symptoms, uh, like ptosis or spreading paralysis, or um, crossing, or the local effects like swelling, crossing the half of, I mean, one major joint. That is what we take it as a cutoff to start off.
yeah. Okay. So, Naim, what do you think? Let's say this patient miraculously still alive, but no antivenom was given after 10 days. Would you still consider giving antivenom?
Yeah, this is a very interesting question. First of all, we need to understand how the antivenom works. So basically, the antivenom, it will bind to the free circulating venom inside the plasma. Basically, it has no role if it's already bind to the receptors. But having said that, there is no way for us to fully estimate whether there is a free circulating venom in the body or not. That's number one. And then the next thing is that we need to understand there is some emerging concept of the venom can be like slowly released into the body. So whenever the snake bite the patient, not all the venom will go into the bloodstream in a while. It has been described, especially in the viper bite, which is the phenomenon that we call as the re-envenoming syndrome, in which that the venom will stay into the subcutaneous tissue and slowly release in the body. But based on the case report, this re-envenoming syndrome has also been noted in the cobra bite as well. So having said that, we need to also understand another thing is that as for now, people are trying moving towards the specific antidote for snake, but it has not go into that part yet. So for now, antivenom is still the definitive management for the envenomation. So if you still have the symptom of envenomation, therefore it is actually justified to give the antivenom. Having said that, we need to understand that how long does the venom stay in the body exactly. Like for the neurotoxic bite, most of the time after like 2 or 3 days, the venom will actually no longer in the body. So if you give it after, let's say, after the 10 days, something happened to the patient, most likely it's not due to the venom itself. So we need to kindly actually look into the clinicals on what is the benefit and also the risk of giving antivenoms. So there is no like a yes or no for every situation. Different patients, different way on how you to approach. But you need to look at the pathophysiology and the character of the venoms before you start deciding what to give or not to give. I think that would be my take on this.
Okay, so this fantastic response. I was waiting for that because let's say in this scenario the patient was intubated in somewhere else, but they didn't have antivenom. Ventilation was continued for days and days, and then they transferred the patient to you, or the patient received or the antivenom reached them already more than 5-6 days. Are we still going to give antivenom or not? Because this is a real case scenario that we just been consulted recently. After 10 days, patient still on ventilator. Are we going to give antivenom or not? So my answer would be in line with all of you, which is no, there is no indication for antivenom anymore. What the patient should get probably to look what's happening up in the central. So CT scan to see whether there are actually what do you call brain injury from the hypoxia or whatever. That's why the patient continued relying on ventilation, not necessarily due to the muscle paralysis issue. Unless this is, of course, a crate bite that we mentioned earlier, but this feature is not what is presented here. A crate bite is typically will be very non-cytotoxic. You will not get the necrosis, but you get a prolonged muscle paralysis due to the destruction of the presynaptic venom, right? So it's because of the destruction, not of the neuromuscular junction, not because of the venom still binding to the receptors. So that's the difference, and therefore the prolongation of that response of recovery is because of the body trying to regenerate back the nerve endings or the neuromuscular junctions. Okay, so yeah, very good discussion. Our moderators, do we have anything else to add on?
So there are a few questions from the audience.
Okay.
Just one query about, I mean, they said from my side also. I mean, is there a role for atropine, neostigmine?
Oh yes, definitely.
Yeah,
yeah,
definitely
you
that
can,
might help in, right?
yeah, but then we have to understand how this atropine or neostigmine works. This is the hydrophonium test. You know, you can use that, but it's an adjunct. It's not the treatment per se to neutralize venom. so adjunct. So we do practice it. We have cases where a patient was partially recovered after giving the antivenom. This is for a cobra bite, but not fully. Some parts of the body are not yet able to function motor-wise. So we give a dose of neostigmine basically to knock off competitively at the neuromuscular junction, and the existing antivenom still in circulation will mop up whatever those antivenom goes into circulation. So we do this, and we do find it quite effective. We've actually we've just recently just last week another case also in Johor, if I'm not mistaken, but it was from a crate bite. So we gave the antivenom for crates. Patient recovered partially also, but not to the full extent. The ptosis persists. So as we know, that's the earliest sign of envenoming. So if it persists, means that it is still some sort of envenoming going on. So we give neostigmine, and we and continue with the daily dose of physostigmine, so that the neuromuscular junction keep on being bombarded by this competitive. And patient recovered after, I think it was about 4 or 5 days of physostigmine, and fully recovered in terms of the ptosis as well. So we have it documented on video. Maybe for the next episode, we'll share the case. Okay? Okay, very nice. Thank you. Moderators?
So,
Yeah, Anjana, you have a question.
yeah, sorry, just one one question. So I was just wondering, how commonly have you seen anaphylaxis due to venom allergy and anaphylaxis?
Okay.
Can this be a case like this? Because we have seen a couple of cobra bite cases
Yeah,
where
you should.
patients even develop Cooney syndrome.
Yeah, then you should report those because
I
it's
published. Yeah,
it's rather you can do it as a case series because it's a rather rare from our side to have hypersensitivity reaction appearing acutely following a snake bite. What we have more frequently is from the antivenom, right? We give antivenom, we get about, from our side, we're using the Thai antivenom. Our recorded rate is between 5 to 30%, but that's also based on the severity of reaction. So not everybody goes into anaphylaxis. Some are just simple rash, itchiness, and so on. So that also we document, so we don't leave those out. But in terms of bite itself, you have to consider why the patient get the reaction from the venom or from the bite. There must be some predisposing incident that patient was hypersensitized, type 1 hypersensitivity, right? So patient might have exposed from snake hiding in the house and then pooping in the house with all the skin and so on aerosolized, and patient got breathe in and developed the hypersensitivity prior to the bite. So without knowing that they are actually sensitive or sensitized to the snake. Okay.
yeah,
But this is well documented also for those working in the serpentarium.
exactly. Yeah,
Yeah. So this is well documented. So we have no argument about that. Our good friend, Dr. Taksa, from the head of snake farm now in Bangkok, QSMI, he's known to be sensitive to snake venom. So he was bitten by a Trimeresurus hagani, and he got allergic reaction. So because of his past experience working with snakes, closely working with snakes. So yeah, so it's not for everybody. So if you have a case, you need to find out the reason why or how the patient got sensitized. So the history detail is very important. You need to go down to the locality where it was or where it happened, and then see if there is actually patient living with snakes, in close proximity. Yeah. Okay. Does that answer your question?
Yes, of course.
Yeah,
Yeah,
okay.
yes. So in our case, actually, we got the patient actually developed Kunis syndrome, so myocardial infarction after that, and then we did the investigations, and there was no atheromatous plaques.
Yeah.
But then, the echocardiogram came to normality after a couple
Yeah.
of days. Yeah, so
So
we
so
published
so
that
so
in Toxicon. Yeah.
yeah, okay. Good. So I mean the main thing was also to look at the parameters of the allergic reaction. So you can do a few testing of the antibodies, IgG, IgM, and so on. IgE, sorry. Yeah, and also there's another one I forgot. You can send those parameters if you have to see whether the patient is actually sensitive, hypersensitive to venom. Okay.
Thank you.
Yeah.
Thank you, Prof and doctors, for the insightful discussion. Let's move on to the next part. Local envenomation was monitored using hourly measurements of the rate of proximal progression. So the initial rate of proximal progression on presentation was 0 centimeter per hour. And then from 10:30 p.m. until 2:30 a.m. the next day, there was a measurable proximal progression at the rate of 3.2 centimeters per hour. And a further episode of progression was observed at 5:30 p.m. on the second day, with a rate of proximal progression of 4 centimeters per hour. On the third day at 8:30 a.m., the rate of proximal progression increased to 5.5 centimeters per hour, accompanied by the development of dermal necrosis at the bite site. There were no palpable lymph nodes draining the affected limb. So, any thoughts from the panel?
I think we can move on to the next slide. I think this is
Okay.
just showing a slow progression and most likely due to improper documentation as well for those doing RPP. Okay.
Okay. So these are the pictures showing the rate of
Mhm.
proximal progression of the
Okay.
patient. Serial investigations were done 6 hourly for the patient. The first test was sent at 11 p.m. on the arrival day. The second was sent at 5 a.m. on the second day, and the third test was sent at 11 a.m. on the second day. So serial focal count showed normal hemoglobin level, normal hematocrit level, and normal platelet level. The total white cell count was 20.27, 27.5, and 22.5 respectively, which are all higher than the normal range. The serum electrolytes show both sodium and potassium. They are in normal range. Serial renal profile show that urea has increased to 10.3 and 14.8 on the second and third test respectively. Serum creatinine had also shown an increased trend from 101 to 149 to 569. Coagulation profile was normal. The liver function test was done once daily, so only twice was done. The results showed slight increase in globulin on the first test. Both ALT and AST were higher than normal range, especially on the second test, which were extremely high, 697 for ALT and 182.3 for AST. Both creatine kinase and lactate dehydrogenase were normal. Arterial blood gas revealed an acidic pH higher than normal partial pressure of carbon dioxide, lower than normal partial pressure of oxygen, and lower than normal bicarbonate. So would profs and doctors kindly interpret the results?
Yeah. So anybody, Anjana maybe or Naim? Is this a typical feature of envenoming?
Yes, I think in the first one, I think the high white
Total
cell
white,
count.
right? Total white
Yeah,
count, right?
yeah, I think it's probably a neutrophil leukocytosis. Although we haven't seen the neutrophil ratio, it's probably it's quite common for any severe systemic envenoming. You get these numbers. What I'm looking at is the creatinine and what basically caused this creatinine rise. Because within about like I guess 24 hours, and then so there's high creatinine. I mean, this kind of rise we often see in viper bites, but I'm
Yes.
not quite sure why this happens here. Whether it's a pre-renal origin, no, I'm not quite sure about that.
I think it's because of the significant tissue destruction releasing the protein into the circulation. But yeah, you're right. There's active leukocytosis. Plus, you can see the liver function as well being affected. CK was
Ischemic
also
kind.
increasing. Yeah, Nikhil, what is it?
Yeah, I find maybe the initial hypoxia and the initial ischemic damage
Yeah.
might have caused the raised liver function test. So and
Yeah.
yeah.
Okay. But it is actually significant after that, right? So it's the day 2, you can see it's 1823 for the AST. So that could be also from the envenoming itself, causing maybe response. But anyway, any other results you want to show us?
So these are the ECGs of the
Okay.
patient, with the first ECG done 20 minutes after arrival of the patient, and the second ECG done 15 minutes after completion of the antivenom, and the third ECG at 4:40 in the morning the next day.
Yeah. Do we have the troponin level?
Unfortunately, we do not have the information on the troponin level.
Yeah, okay. What do you guys think? Is this
Yeah.
a cardiotoxicity or is it just injury from the hypoxia?
Yeah, because I think the CPR was administered to this patient. This is quite tricky. And I think the cardiotoxin from the Naja Sumatra Nabat, so sometimes quite tricky whether it's really there or how severe it is. But we need to look multiple factors. I'm just wondering whether is there any echocardiogram done for this patient? Bedside echo? How's the cardiac status for this patient?
Unfortunately, we do not have information on the echocardiography.
Because I also agree with the previous panel that the worsening of the renal function, the rising of the CK, that can be due to the both the cytotoxic effect, the hypoxia, and also the ischemic changes. But whether this effect is post cardiac arrest, the ECG changes or not, whether it is a true cardiac toxicity from the snake bite, it's not easy for us to say at this point. But regardless, I think it will not really change the management. It still remain the supportive management at this point.
Okay.
There is progressive ECG changes between 4:12 and two consecutive ECGs. Um, I think we should, if we get a better idea about the troponin value and
Yeah.
maybe a 2D echo, that would solve it, like whether there is
Yeah.
any
Yeah. So
local.
maybe serial monitoring also may be of help as well to see if there's any evolving changes from the acute to something more established, right? Okay. Right. Okay. So what anything else, guys? So we're not going to start thrombolysis. That's the main thing. It's not an obstructive issue. Yeah. Okay. Sorry, Naim, you're muted.
Oh, and of course, since patient still intubated and you get this giant inverted T wave at the lateral leg, another thing to consider is whether there is any hypoxic changes to the brain. So did we perform any CT brain from this patient to rule out that this ECG changes is from the brain?
Very good. Moderators, do we have CT of patient?
If I'm not mistaken, we do not have the CT brain results for the patient.
Okay.
Oh, yeah, we do have. Yes.
Was the
Okay.
electrolytes normal at this point? Potassium, calcium.
The electrolytes are normal.
Normal, right? Yeah.
Yes.
Fine.
And yeah, we do have the results of the CT brain. So there is a reduced gray-white matter differentiation with a mild effacement of the bilateral cerebral sulci.
Okay. But no image. You don't have the
No,
image?
we do not have the image.
Okay. Okay. So is there a secondary injury to the brain, you suggest, with that result?
There's some hypoxic event has already occurred.
Yeah. Yeah. So we don't really know exactly then when patient is not having the CPR. I mean before CPR, right? So we know that is 10 minutes is already causing permanent brain damage. So we don't know how long exactly patient collapsed before arriving to the ER for the CPR. Okay, so next, what the moderator can provide us about this case as we progress? It's an interesting case, though. Yeah.
Yeah, it is.
Yeah. Okay. Complications.
Okay, so before I share the complication that the patient has developed, I would like to invite the panel to discuss the complication that you would anticipate in this case.
Yeah. I think we already said that it could be from the local one. Then there's the brain. I think the most important. And then also possibly secondary infection developing, and also just now we have already thought about the other multi-organ failures, right? Kidney, liver, and so on. Yeah. But the main
Yes.
thing is the brain. Yeah.
So these are the complications that the patient had eventually developed. So includes hypoxic ischemic encephalopathy, aspiration pneumonia, which intravenous unison was given, post-cardiac arrest myocardial dysfunction, oliguria acute kidney injury, and ischemic hepatitis.
Yeah, unfortunate for her. It's not just a simple envenoming anymore. That's what we are looking at. Many cases that came or late. We may be correcting the current envenoming, but the injuries that already happened, and that will take up most of the management toll for this patient. Yeah. Okay.
So despite intensive management and supportive care, the patient unfortunately succumbed after 5 days.
Yeah. Final words from, or is there a question? There are questions you want to ask us?
Yes, there are a few questions from the audience. So the first one, is it necessary to apply pressure immobilization to the bitten limb while giving symptomatic treatments when the antivenom is not yet available?
Anjana?
Yeah, so I think the circumstances basically dictate that, especially in cobra bites, you get severe tissue swelling, and therefore, whatever the interventions that we do that generate pressure locally might be leading to a compartment syndrome. So we have to be very careful. In our setting, we basically discourage any application of pressure immobilization for any snake bite, because in our setting, 90% of the bites are either due to vipers or cobra. So all cause local tissue swelling rapidly. So I guess it is also the same here.
Yeah, the same here. Pressure pad immobilization is advised in some of the elapids, but then it's very difficult to understand whether it's an elapid or a viper, especially because it's the other way around. Like cobra has local toxicity, and Russell's viper also shows a bit of neurotoxicity. So it's very difficult to identify in first place. So we also don't follow any sort of any pressure immobilization. But then again, in this case, especially in cobra bite, stabilization of the airway and breathing is at most priority. Maybe if antivenom is not available, I think all effort to secure the airway and breathing would be better strategy. Yeah.
Yeah, I agree. Naim?
Yeah, the ideas of pressure bandage immobilization is because we think that the snake venom will travel through the lymphatic system. So by applying the pressure bandage immobilization, you actually rest the muscle to reduce the contraction. But having said that, we need to look at the benefit and also the harm from this treatment. So this is why, for me, I will recommend look at the site and see whether there is any tissue damage or not. So if there is no tissue damage, then perhaps it's quite safe for you to apply the pressure bandage immobilizations. But if there is already some tissue damage there, then if you apply more, the venom will be concentrated there and cause more damages to tissue. So the safest treatment was just to immobilize the limb and bring to the hospital as soon as you can get.
Okay, that's good because another thing is that when you do that pressure bandaging, you will not be able to see the underlying tissue anymore, the underlying skin. So you will definitely block out your capability to see whether it's getting worse or not. That's one thing. Immobilization alone will be sufficient. Okay. Any other question?
Yes, there's another question. So, is there a specific time frame we can expect complication to occur from envenomization, or is it dependent on the species of the snake?
Okay. Anjana?
Yeah, so I think the complications actually are a mix of the venom effects as well as other interventions as well. So, so therefore, I guess I mean there's no I mean we are only here focusing on the acute effects, but of course, when you take the long-term effects into consideration, that might go on for months. But in this snake, probably the local effects might seem to be not that severe. There's no extensive tissue necrosis, or therefore, I guess the complications won't last for that long. I guess, in this kind of patient, I guess, where the local effects are quite, limited. But other than that, in other snakes, I guess if they lead to acute kidney injury, like in viper bites, probably some of them might lead into a chronic renal failure. About 1/3 of the patients in our settings that we see. So then they become, even some of them becoming dialysis dependent, end up to the end stage. So it depends on the context. But in this in this kind of cobra envenomings, I guess unless you develop ischemic problems due to the ischemia or the local effects, otherwise I think most of the cobra bites they would recover completely.
Yeah, okay. Nikhil, you want to add something? Or Naim?
Yeah, I think Prof. Abhana already mentioned some quite valid points. So basically, it depends on not only the venom but also on the host as well. So different people they have a different reaction to any toxicant that enter the body, and we need to understand that the venom is actually a composition or the mixture of few other things. There is a enzyme, there is some toxic substance, and these have a different onset of time how they works. And whenever the snakes bites you, there's also different dose that enter the body. So we cannot really say that there is a specific time frame whether it will develop or not. So it basically depends on the species, the geographical. So even for example, like you have the same snake like the Naja sumatrana, those that you have in Semenanjung, the composition of the venom with whatever we have in Sabah, for example, might be not the same depending on the diets of the snakes, depending on how far the venom have evolved. So we cannot really actually put a specific time frame on how long or how fast it will occur.
Yeah, we do get this question quite often. How long will my heart stop after a bite? It's difficult to answer. Yeah, so it's not about that. It's about getting to the emergency care as soon as possible, right? So no matter if you have or not there's any symptoms. Yeah. Okay, so can we move on to the next case?
Okay. Thank you, profs and doctors, for the valuable information.
Okay, so now I'll be presenting the second case. So this case involves a 2-year, 8-month-old Russian boy, previously well, who presented following a suspected jellyfish envenomation, which is most likely a box jellyfish, on 15th November 2025. This incident occurred while the child was bathing in seawater, and the sting involved both lower limbs. So I'll explain about the event timeline. So the child was initially playing and bathing at the shoreline of Pantai Chenang, Langkawi, when there was a sudden onset of severe pain in both lower limbs. The parents subsequently noticed linear erythematous streaks over both calves, after which the child became pale, collapsed, and was unresponsive. So, but the exact timing of the sting is uncertain. At 7:45 a.m., the child was brought to Chenang Clinic, where the child was noted to be pale and apneic. However, no medical intervention was provided due to the absence of a doctor, and the parents were advised to proceed immediately to the hospital. During transport, the mother initiated CPR upon noticing absent breathing, and CPR was continued en route, although it was stopped midway for unclear reasons. The child arrived at Hospital Sultana Langkawi at approximately 8:15 a.m. No first aid had been administered prior to arrival, and residual tentacles were still attached to both calves, supporting a diagnosis of marine envenomation, which is most likely a jellyfish sting. So, any I'll open this for the panel to discuss just regarding the history. Any thoughts?
Maybe Naim want to start off.
Yeah, I think this is reading of this first slide is still quite a sad event, you know. This child is a 2 years old small children. So based on our experience, mortality following the marine envenomation, especially the jellyfish, is quite more pronounced in a smaller child because of the total body surface area, and the more venom load will goes into the body. And the things about these venoms that it will directly hit your cardiovascular punya systems. So if you are able to provide the first aid care, effective CPR, I think the chances for the patient for you to revive the patient is still there. So it is really unfortunate that this occur in our local setting, that the patient was brought to the clinic. By right, everybody can provide the CPR and things. So I'm not quite clear whether why this mother was directed to go to the hospital by themselves. So the better response would be for the patient to be attended and to activate the 999 and send the ambulance to retrieve the patients. That would be a better things to do in my opinions. But having said that, um, we do have cases of the jellyfish sting that we need to do CPR, but then the downtime is too long, so it's quite almost not possible to revive whatever the venom effect that happens. So just to clarify, this patient they bring to the hospital by themselves, is it?
Yes.
Yeah,
Yes,
I
doctor.
think
Yeah.
yeah, I think that's quite unfortunate. So the take home message is that you need to understand that in the environmental injury caused by envenomations, the the envenomation has a good chance for you to revive if the patient develop the cardiac arrest, provided that you provide the effective CPR to the patients and provide the necessary treatment once the patient come to the hospital. But once you disrupt the chain of life, in which that you stop the CPR and patient already have the hypoxia, ischemia, so there is no way for you to actually to revive the patients.
You mean the brain, right? So
Brain, yeah, once the brain stop.
our main concern here is the hypoxic to the brain,
Yes,
like the first case just now. So okay, right. Jana, you have jellyfish, box jellyfish?
No, we don't get cases like that. Only I studied in Australia. Nothing.
Yes.
But from my knowledge, again, I would like to ask. So in this, box jellyfish envenom, the cardiac arrest is sustained, so you are required to give prolonged CPR compared to other instances. Is it like is the
Yeah, so we have to look at the situation as a whole. I think the doctors would have just called off quite early the CPR if just a adult or local, but this is a bit more complex. Involve non-Malaysian and Langkawi. It's a touristy place, and there are a few other things that comes into play, and therefore that's why there's a prolonged. I think it took them 1 hour and 30 minutes of CPR before ROSC achieved. So the question is, what can we do after, right? So is there still a role for antivenom or not? Is there a role for really going for all out for this patient, or are we going to prepare for something else, right? So that's the issue that we encounter with such a situation. It's not really a clear cut. Okay, we don't have to do CPR for this child. Yeah. Okay, that's the dilemma that we do have. Okay, so but I just want to just ask, what about the residual tentacle still attached in both calf when patient arrive to hospital? Anything that we can do to tackle this, or are we just going to just leave it there? Naim?
Yeah, the idea is that whenever the jellyfish, the tentacle contact the body, the stinging cell or the nematocyst is still there. So there is no way for us to predict whether all the nematocysts have fractured or not. So we always assume that whenever there is a tentacle, there is possible nematocyst that has not been fractured yet. So our first aid is basically to stabilize this nematocyst that is not been ruptured and to remove the potential hazard from there. So there are few methods on how we disable this nematocyst. So if you are in the hospital setting, you can use any lignocaine spray. And although it's controversial, the vinegar is still recommended to actually to disarm the nematocyst. But if you do not have anything, the latest ILCO recommendation, AHA recommendation is actually to use the seawater to rinse it with the seawater and remove the tentacle so that you can actually reduce the chances of new venom being injected into the body.
Yeah, so that's good. So can we move on?
Okay. Moving on the initial blood. Okay, so before that,
Wow.
this is the picture of the patient. So any comments on this before we move on to the investigation?
Nikhil?
Yeah, it's a typical rash of jellyfish with
Box
probably the
jellyfish, right?
tentacles still attached, box jellyfish. Yeah.
Yeah, multi-tentacle.
We also do have box jellyfish along the Indian coast, but then very few cases, normal jellyfish stings I've encountered, but that not any box jellyfish. Yeah. So what I remember is it's called some flagelliform rash or something. Yeah, with some nematocyst attached. We still use vinegar over here. In fact, there is a small jelly safe kit which is developed by the fisheries department for the fishermen and tourists. Yeah.
Yeah, yeah, okay. Anjana, what do you think if we have something like this in Sri Lanka?
No, we haven't seen. Of course, box jellyfish is present around some parts, but we haven't seen a single case.
Yeah, when you were in Australia, did you encounter any
So
of this?
that was in Queensland. So when I
Queensland,
was
okay.
so in Queensland, I think there are time to time reports.
Yeah, we do encounter it quite not frequent, but it's nothing. It's not rare for us. So Naim is right smack in the middle of the controversy of the box jellyfish. So maybe Naim, what do you think about this? If you see this skin
Yeah,
rashes.
this is a shoeless appearance. Some will call it a shoeless appearance of that is more significant. There is a pathognomonic of the chirodropic box jellyfish sting. So for box jellyfish, basically you can divide into the one tentacle box jellyfish or the charybdite, and the other type is actually multi-tentacle box jellyfish. So meaning that from each corner of the box, there will be a lot of tentacles there. So chiro means the leg. So multi-tentacles mean you have a lot of tentacles there. So the things about this box jellyfish is if you look at these pictures, the especially at the left sided, the first and also the low pictures, you can see that the aerial might be not too big but it is very dense lesions. So meaning that there are a lot of tentacles that been attached there. So most of the time, sometimes people miss or underestimate the burden of the jellyfish sting. For example, that when they look at the sting, they calculate the total surface body area, maybe it is less than 10% or less than 5%. But what they do not realize is that sometimes it was very dense with the so many tentacles attached to that part of the body. So meaning that there are more nematocysts being attached and more venom load will go into the body, and it can cause more burden to the body to have such a massive influx of the venom into the body. And what you need to understand the differences between the venom between the box jellyfish and also the snake that we discussed just now is that the venom of the jellyfish that are very small in numbers and there are much more there, and they travels rapidly to the organs, especially the heart and also the muscles. And the venom they are called the pore membrane formation, and they are very specific to the heart and also to the lungs. So they travel very fast, they are small, and they are very specific with the receptors. So hence, the collapse is expected to occur in quite a very fast, rapid. So that's why that intervention must be done quite rapidly.
Okay, so I think nothing much we can do on site except for public CPR. I think that's the most important message that we should get things out. So, okay, anyway, any progression of the patient, moderators?
Okay, moving on. So on initial lab investigations, which was taken at 6 p.m. on 15th of November, the white cell count was markedly elevated, which was 27.32, which suggests like an acute stress or inflammatory response. But by the next morning, the white cell count had reduced to 18.2, which might be an early response to the treatment. Hemoglobin and platelet counts showed a mild downward trend but remained within acceptable ranges. The renal profile showed progressive electrolyte derangements, particularly hypernatremia, with sodium rising to 157 millimole per liter and a rising urea level, which can raise concern for dehydration. Additionally, there was hypocalcemia, hypomagnesemia, and hypophosphatemia, which may also reflect cellular injury and might be rhabdomyolysis as well. So, further investigations revealed that the liver function tests were markedly deranged, with AST was 1499 and ALT was 598, which indicates severe hepatocellular injury, likely secondary to the systemic envenomation and which happened during the cardiac arrest. Albumin levels were low. Coagulation profile was prolonged with an INR of 1.91, which is consistent with the possible venom-induced coagulopathy. Muscle injury was evident with a very high CK level, creatine kinase, of over 10,000 and LDH of 2,152, which supports rhabdomyolysis, which is a known complication of box jellyfish envenomation. So importantly, the diagnosis was supported by a positive sulfon tape test, which demonstrated there was nematocyst, confirming the jellyfish envenomation. So on the okay, so to the panelists, anyone has any idea what species is this?
Okay, we give to Nikhil first. Naim last. Have you seen a hepatocyst before?
I've seen the pictures, but then not in real, in fact.
Okay, so these are really nice pictures. So, what can you see? What can you describe? What this nematocyst looks like? Or nematocytes. There's several, right? Many. It's in cluster. Anjana?
No, I'm not quite sure.
Okay.
Yeah.
Yeah. So maybe the moderator can point to what we are looking at.
Yeah, so the species name is Chironex species. So particularly, it is Chironex yamaguchi. So I think maybe we can Google up upon that.
We
But then the indication is that, sorry, the nematocyst showed that it was ruptured mastigophore types, and the cucumber-shaped nematocyst was consistent with the Chironex species thing.
Okay, so since that description is done by Naim, maybe you can comment on it. So it's this cigar shape or this elongated what do you
Yeah.
call? Yeah.
It is very interesting to understand that inside the nidocyte or the stinging cell, you have a different type of nematocyst. So it have different function. Some of the nematocyst, it has the venom inside it, and some of it will function as to attach the skin and whatever structure that they are able to get by.
To
So
anchor.
to anchor with so naming this nematocyst, you need to look at the shape of the nematocyst and see the relationship between the tubule of the length. So like for this type, you have this very elongated cucumber shaped nematocyst. So definitely it's a nematocyst that bear the venom inside. And when you look at the tubules, there is that something that coming out from the nematocyst is quite long. So this is what we call the mastigophore types nematocyst. So based on the nematocyst alone, you can actually have a brief idea whether this is what type of jellyfish, whether it is a box jellyfish, whether it's a single tentacle or multi tentacle. But having said that, it's quite different for you to say the exact species name. For example, like if you look at this sting in the slide, you can say that this is Chironex species. But so far, we have three types of Chironex species that have been described in the literature, which is the Chironex fleckeri, Chironex yamaguchi, and also the Chironex indrasaksaje. So far, for the untrained eyes, even for me also, I'm not going to be very 100% sure to say the exact species of that. But whatever that I see in this slide, this look resembles more of the species that we found in Sabah, which is the Chironex yamaguchi. And based on the clinical presentation on how fast the patient died, so it is possible that the species that is responsible in this case is also Chironex yamaguchi. But having said that, if you look at the map of the stung area, it also has shared the similar water with the Thailand. So the Thailand also we have another type of the Chironex, which is the Indrasaksaje. So I think the best way for us to know what are the culprit that involved in this species is actually to do a field trips to get the jellyfish there, to identify the exact species and to compare the nematocyst from that jellyfish itself and whatever we have from the skin. But having said that, it is also quite tricky because once the nematocyst attached to the skin or it already ruptured, the configuration of the nematocyst will be different. So it will be slightly swelling up and rupture. So based on whatever that we have, it's definitely a Scaronex. But what the exact species, we still not sure yet at this point. Right.
So would the attached tentacles just now when we removed it, would that be a bit more helpful compared to just from the skin sampling like this?
Yeah, I think if you can have the tentacle itself, you can actually preserve it in the formalin, and then later we can examine because there's still high chances for you to find the non-ruptured nematocyst from the tentacle itself.
Yeah, and we already fixed it, right? So
Yeah.
it doesn't discharge. Okay. All right. So yep, that's the dilemma. But this is just all academic, right? This is nothing to do with how knowing this will save the patient. So it's purely academic in terms of identifying the species. Okay.
We can okay for the management. Just the child actually suffered a cardiac arrest but achieved a successful return of spontaneous circulation. And post resus, he was intubated and ventilated and admitted to the ICU. And immediate local management included warm water immersion of both lower limbs, removal of tentacles and nematocysts, and skin sampling for identification. For post-ROSC vitals, the blood pressure was 90/62, heart rate was 114 beats per minute with adequate oxygenation and ventilation, but borderline urine output indicating probably a shock physiology. He was managed with IV midazolam for sedation and IV adrenaline for inotropic support. And given the high suspicion of box jellyfish envenomation and systemic toxicity, Box jellyfish antivenom was arranged from Kuala Kedah with a plan of 3 vials over 1 hour under close monitoring. Once stabilized, the decision was made to transfer the patient to a mainland pediatric ICU for ongoing advanced care. However, despite the intensive management and care, the patient passed away 4 days later. So, I would like
So
to
the question, yeah, okay.
yeah, I would like to invite the panel's view on the management of this case, whether is there any alternative approach that could be considered on
I would
management.
rephrase that question to, is there a role for antivenom for this patient? What do you think? Because this is something that might not be well known to many. We have antivenom for box jellyfish, which we import from Australia, and it was just recently stopped in Penang. Otherwise, it was mainly in the Sabah hospitals because we have higher rate of incidence there. So what do you think? Is there a role for antivenom for this patient, for this unfortunate child?
Yeah.
And having all the trouble, trying to transfer. Yeah.
To clarify a few things first. Number one is how long is the CPR, and is there a downtime? The time without the CPR was how long actually?
So from the site, it's actually just now about 1 hour, right? About roughly 1 hour, no CPR transport. How do you do CPR in a Grab car? So
It's
unfortunate.
about half
Yeah.
an hour.
Yeah. So and then the CPR in the hospital lasts about 1 hour and a half, as I mentioned earlier. So we got ROSC, but as you know, the pathophysiology, the child having cardiac arrest is mostly because of hypoxia. Also, you have enough oxygen and so on, might get back the heart pumping quite strongly without and the child was on inotrope support as well, in 3 or 4 prior to giving antivenom.
Yeah.
So is there a role for antivenom?
I think we discussed in the previous case during the snake bite that the role of antivenom is actually to bind to the free bound venoms. So like in this case, it's very tricky because the antivenom for the box jellyfish is also controversial. So it is initially meant for Chironex fleckri, which is the other species that been developed or found in the Australia. But if you look at the literatures, there are quite controversial for a few things. Number one is that they are not sure how much dose actually effective for the box jellyfish stings. So, for example, like if the patient has already developed the cardiac arrest, they say that the recommendation dose, which is 6 vials, might not adequate. That is number one. Number two is the time. When would actually should you give the antivenoms? So based on the literature, the best time for you to give antivenom is immediately after that the patient was been envenomed. So in this case, the time is quite prolonged, and patient has been doing CPR for so long. So we do not know the function of the brain whether it is still intact or not. So giving antivenom is not really like something that you give and patient will survive. Need to consider many other things. If you ask me personally, based on the recommendations, I will not give the antivenom to the patients because I will still keep it for those who have more chances to recover because it's very expensive and not widely available. And to give the
Yeah.
patient, to give it to the patient who's already like with the brain's already gone, with multiple organ injury and the duration is already prolonged. So the benefits might not be too good in this case.
So this is an intervention which I said just now is more political rather than the actual clinical. So if we look at the uh, outcome is going to be not really beneficial for this. So the giving is mainly just to say, oh, we have antivenom, we've done everything that we can. So adding more like this is going to be just a waste of resources. So I would strongly recommend to look at empowering our healthcare service to have it actually in Langkawi if they have, rather than have to transport it from somewhere else, takes hours. So if you want to give an antivenom for box jellyfish, you have to give early as well. So yeah. Anyway, it's different from snake bite in a way, the snake bite envenoming. Okay, so next.
That's it for this case, Prof. But I do have one question.
Yeah.
So like, what protocols or steps can like a bystander do or improve bystander response to a suspected box jellyfish envenomation?
Okay. Maybe the panelists would like to respond.
Yeah, I think
Yeah, please go ahead. Now, what I think is like, especially in a resource limited setting like our country, like, so if there is some exposure to box jellyfish envenomation and if it's causing systemic complications, so bystander CPR, as sir earlier mentioned, that would help in maintaining the airway and also bystander CPR. That is one thing which can be done as a first aid, and then quickly transfer to an hospital or a clinical facility where ventilation and other strategies can be applied. That is one thing. Apart from that, what I can think of when in general about jellyfish envenomation in our place, we have we have kits like jelly safe kits, again contain um, vinegar, or people are also advised to wash in warm water to remove and to pick up the tentacles using a tweezer and to avoid dropping. All those things are the first aid things which can be considered for jellyfish.
I think there's a lot of fixation on vinegar. It's not really going to neutralize the venom. So that's the main thing. People really thinking, finding vinegar and whatever, hot water and so on to neutralize the venom. It doesn't do that. So it's purely for preventive measures for the nematocysts from discharging, and also for pain control, but it's not really going to neutralize the venom. So people need to understand that. So another thing I think maybe Naim would like to ask, expand a bit about public awareness.
Yeah, I think that the very first thing that we need to understand is to acknowledge that the risk or the threat is present there. And once we acknowledge the risk or threat that the box jellyfish is there, then we can do the mitigation for these cases. So public awareness education is one of the most important thing to do. And based on this case presentation, I think that not only the public need to be educated, but also our healthcare providers. So I think that people did not realize or understand the magnitude of the box jellyfish stings. So if we are able to go back to the time where it occurs, apart from the acknowledging that the box jellyfish is there, the public need to be educated about the CPR, and also the healthcare provider also should know that when they get this kind of cases, they should anticipate that the patient might go into the cardiac arrest and hence activate the retrieval teams early. And other thing is that the prevention that they can do, if they understand that there's a jellyfish in the water, they need to know whether it is really good things to go into the water or not. Let's say that they still insist on doing the water activities, then there must be necessary action need to prevent or to reduce the risk of exposure to the jellyfish. For example, like you're having the proper jellyfish net, or you wear the appropriate clothes that can actually reduce the stinging to the bodies. And following that, of course, you can have those first aid treatment at the beach, and to also train the those who are in the industrial or in the tourism industry with appropriate knowledge to manage the jellyfish stings. I think that would be the things that can be done for the society.
Yeah, so prevention is better than cure. I think that's the most important for this particular issue. Just to give you a heads up, we'll be going to Langkawi in early February. We're going to have some programs in Langkawi, 3 to 6 February next year. So, okay. All right. So,
Prof,
do we have time?
sorry,
A question?
Prof, just to add on, so after this incident, Jabatan Perikanan Langkawi was notified and there was a public warning signage. It was actually initiated at Pantai Chenang regarding box jellyfish presence so that the visitors are more aware of it.
Yeah.
Yeah.
Yeah, that's a bit too late now. We've already sort of alert them more than 5 years ago. So anyway, yeah. So anything else you want to add on for this case?
No, Prof, I think this case,
Okay. Do
unless
we have
you...
time for a quick third case? For 10 minutes or no?
Maybe we can just give a
Okay,
short
just run
history
through.
and yeah,
Run
just run
through
through,
us.
Prof.
All right,
Yes.
sure. Okay, so this is a 48-year-old Malay male with no significant comorbidities apart from prolapsed intervertebral disc. The patient developed shortness of breath, dizziness, and one episode of vomiting at around 8 a.m. He denied any chest pain, palpitations, or diaphoresis. He initially rode his motorcycle to the hospital to seek treatment. However, on the way, his dizziness worsened, prompting him to stop at a petrol station. He was subsequently brought to the hospital by ambulance, which was called by bystanders. In the emergency department, he was able to provide a brief history stating that he had consumed ikan buntal, which is a broad term used by the local people that could be referring to porcupine fish as well as pufferfish earlier that morning. Unfortunately, further history was unable to be obtained from the patient as he was quite unstable at the presentation. So the first question asked by the Rex was, the dish was cooked with just the flesh or including the roe? The attending doctor claimed that no roe was observed in the dish. However, part of the fish skin was present. The dish had an unpleasant odor, possibly due to poor preparation. And has anyone else tasted the dish, the fish prepared at home or at a restaurant? So the answer provided by the neighbor was, the patient lives alone. He usually buys fish from Kota Kinabalu night fish market and cooks for himself. So most probably he's the only one who tasted the dish. And is it possible to get the sample of the fish and send it for analysis? And the answer to this is yes. Later that evening, the patient's brother broke into the house and got the sample of the dish. So these are the pictures of the dish provided by the brother. So profs and doctors, do you have any comments on the pictures?
Doesn't look tasty though. So, okay. Okay.
This pufferfish is not actually a delicacy in our part of the world, but then there are few cases documented because of having it in a dried form, also as a fresh form, without knowing actually it is poisonous. So,
Yeah,
yeah.
so interesting you say dried form, meaning that they dried the fish and then they cook it later on, is it? I assume that's the case. So tetrodotoxin is a heat stable, it's not heat labile, so it just retains the toxicity even after you cooked it. So this case is cooked as well. So this patient do get poisoning from it. Okay, so continue.
So at the emergency department, general examination of the patient revealed that he was alert but slightly drowsy with a GCS score of 14, E3, V5, M6. His pupils were equal and reactive 3 mm bilaterally. He was not tachypneic and his speech was slurred. Capillary refill time was less than 2 seconds. Vital signs were as follows: blood pressure of 199/111, pulse rate 91, blood glucose 8. So on respiratory examination, the lungs are clear. Cardiovascular examination revealed a dual rhythm with no audible murmurs. Abdominal examination was unremarkable with a soft, non-tender abdomen. Neurological assessment revealed generalized hypotonia. Power assessment showed muscle power of 3/5 on the left side and 2/5 on the right side, involving both upper and lower limb. Deep tendon reflexes were reduced bilaterally, and the Babinski sign was positive on the right side. The BFAST screening was positive, hence stroke alert was activated immediately, and urgent CT brain and CT angiogram of the cerebral vessels were performed, which show no evidence of acute infarction or intracranial hemorrhage, and no large vessel occlusion was identified. So, shortly after returning from the imaging, the patient's condition deteriorated rapidly. His oxygen saturation suddenly dropped to 60%, accompanied by loss of consciousness and absence of spontaneous breathing. Cardio monitoring revealed asystole, and cardiopulmonary resuscitation was initiated immediately. The patient was intubated and mechanically ventilated. A total of 3 cycles of CPR were performed with intravenous adrenaline administered during resuscitation. During the course of resuscitation, the patient developed an unstable supraventricular tachycardia, for which synchronized cardioversion was performed successfully. Following the cardioversion, return of spontaneous circulation was achieved. So despite initial stabilization following the return of spontaneous circulation, the patient remained persistently desaturated over the subsequent 7 hours in the emergency department, with a progressive increase in the oxygen requirement despite being on full ventilatory support. On reassessment, the patient was intubated and ventilated with the pupils dilated to 5 mm bilaterally. Peripheral perfusion remained adequate, and the vital signs of the patient, BP was 153/97, heart rate 97, and oxygen saturation 89%, and the lung auscultation revealed generalized crepitation over both lung fields, and endotracheal suctioning was performed, yielding a copious amount of frothy pinkish secretions. And cardiovascular assessment showed dual heart sounds with no audible murmurs. There was no peripheral edema, and peripheral pulses were palpable and equal bilaterally. Investigations was done for this patient. His full blood count, renal profile, and liver function tests were all normal. Arterial blood gas revealed a pH of 7.22, bicarbonate 20.1, which is lower than normal. Partial pressure of carbon dioxide 49, which is slightly higher than normal. And partial pressure of oxygen 87, which is normal. And the bedside transesophageal echocardiography revealed heart with a good contractility. There was no right ventricular strain, no pericardial effusion, and ultrasound of the lungs showed generalized B lines over L2 to L4 and R3 to R4 levels, and there was no pleural effusion. Chest X-ray showed acute pulmonary edema features. So at this point of management, attending doctors had planned to continue current ventilator settings to provide supportive management, to report to the health inspector as food poisoning from pufferfish, and they wanted to send the food sample for tetrodotoxin analysis, but the medical team there was unsure if there was any local laboratory service that could help to confirm the species based on the sample. Yeah. Basically, that's all for the case.
So, okay, thank you so much. So did this patient survive?
Yes, eventually the patient survived.
Okay, so it's about time. There's no antidote for tetrodotoxin poisoning. It's just time and supportive therapy. So at least somebody survived today, right? So we had 3 patients, so at least one survived. So that's most important. It just shows that how important CPR is. If you've done early, it can actually survive. Okay, in the end. So all 3 had CPR, but pre CPR will be determinant of how the patient survive, the outcome of the patient, right? Okay, so anybody would like to comment? A few last words about this case. We have about 4 minutes. Naim or Sisin Sabah.
I think that the one that I want to highlight here is recognition, early recognition. I think most of the center in Malaysia, we are pushing towards to achieve a patient with stroke to detect early so that we can thrombolize or send to thrombectomy. But we need to understand that sometimes there are conditions which is a stroke mimic who appear symptom like a stroke, but we need to also exclude the environmental causes like diving emergencies or also the pufferfish poisonings. So like in this case, unfortunately, the patient actually told the paramedics that he ingested the ikan buntal prior to collapse, but the message was not conveyed to the treating doctors in the emergency department. So that's why they immediately sent for the CT scan. So I think that's the thing that I would like to highlight here, the stroke mimics and the important to recognize early.
Yeah, that's very important. A lot of people were distracted with some information which needs confirmation, right? So pufferfish is an endemic issue in Sabah, where several cases. Actually, there was another 2 cases after this case in Kota Kinabalu. Also quite similar, buying this pufferfish, porcupine fish actually, from the market. And they sold the fish. When we saw the pictures done by the survey of the local health office, they showed the fish is de-skinned, but the raw was also sold together with the flesh. So the issue is about the raw that might have contained more tetrodotoxin concentration compared to the flesh. Okay, right. Yeah, maybe Nikhil and Anjana, you want to have last comment about this case before we close?
Yeah, so this is again nicely connects with the other 2 cases as well. I guess everything actually directs down to the point where, how important the CPI measures like CPR are. Then, in this case, obviously there's no antidote, specific antidote. Even in the cases where specific antidotes are available, the role of antidote is actually quite limited, so that to get the maximum out of the antidote, the basic things like early identification of the risk features, as well as what we can do in terms of CPI is quite important. I think that's a very nice take home message, I guess, for everyone, because in our settings, what we usually think is, what saves is the antidote. Yes, of course, but in circumstances where other factors also favors. That's what I learned from this, I guess.
Thank you. Nikhil?
Yeah, one thing again, awareness about such a toxin. So I mean, such a poisonous fish. To those people who are not much aware about it, like especially in areas which is not a natively eaten fish, then that would be good. And also, as we told, in a case of absence of antibiotic, uh, the CPR will really help in. Also, supportive treatment, especially critical care treatment, would help in. Yeah.
Yeah. Okay, so I think we pass back to our moderators for next program
Okay.
next part.
So, thank you to all the panelists, Dr. Naeem, Prof. Anjana, and Dr. Nikhil, as well as our advisor, Prof. Khaldun, for sharing your expert opinions in the clinical management of toxin-related diseases during our case discussions just now. So, we have prepared a quiz for the audience. So, Prof. Khaldun will share a Kahoot quiz. Please scan the QR code or key in the PIN number to join the quiz. And he has actually prepared a big prize for the winner for the quiz. So, please try your best to score. And right after this quiz, we'll be having a photo session and a QR code for feedback and certificate of participation. So please stay with us till the very end.
So let's see. Sharvin Raj, number 3. Rashidi, number 2. And the champion is NR. Okay, please, NR, please give your details to our organizers so that we can give you your prize. Okay, so thank you so much, everyone.
Okay, moving on. We would like to invite Dr. Muhammad Naeem for a closing speech.
Right. Thank you to the organizing committee for organizing such a wonderful program today. It's already the season 5. This is a very impressive effort. So I would like to take this opportunity to thank you, our moderator today, Yinju, and also the Saloni. Not to forget the other co-speaker, Prof. Dr. Ajana, and also Dr. Nikhil. And of course, the program advisor, Associated Professor Dr. Ahmad Khaldun. So I just would like to give a bit of summary for our discussion today. So the first thing that I want to highlight is that envenomation is one of the common presentation to the emergency department. And for the patient who developed cardiac arrest following the envenomation, it is one of the reversible causes for the cardiac arrest, provided that you able to sustain the chain of life for the patients. Then number two, I would like to highlight here is the early recognition for the patient who potentially develop the envenomation syndromes. And while the antivenom is the definitive management for the envenomation, some species they do not have antivenom, or sometimes in the certain places we have a limited access to the antivenom. Hence, the supportive care is needed so that the venom effect will subsequently wean off from the body. And we also need to understand that prevention is the most important things to avoid the cases of envenomations. And it is actually take the whole society approach to tackle the issue related to envenomations. So the very first thing that the society need to understand is to acknowledge that there is a risk of the bad sequences following the envenomations. There is no need to deny the presence of venomous species in our places. The mitigation need to be done in order to reduce the risk of death following the envenomations. And finally, the educations. I think that the organizer have done such a wonderful job in organizing these things. So I remember that for the past 15 years when I was a medical student, my exposure towards treating the venomous animals is very limited. And even when I become the medical officers, I am very stumble upon managing the cases of snake bite. But thankfully, under the guidance of Prof. Khalduns, I slowly learns about this topic. And I think that by exposing this topic to the medical student at um, early learning points, that will be a greater benefit to improve the patient's care. So with that, thank you for joining our sessions. Hopefully we can meet up again during the next sessions.
Thank you. Thank you so much, Dr. Naim. So before we end our webinar, everyone, please turn on your camera so we can take a group photo together. Okay. 3, 2, 1.
Bye. Thank you,
Okay.
everybody. Well done. See you
Thank you,
again
Prof. and
next year.
doctors.